and welcome to the Alabama Public Health Training Network. I'm Bill Kennedy with the Alabama Department of Public Health. Thank you for joining us today for our program, addressing the needs of individuals with SUD and OUD in the age of COVID-19. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on our screen now and will appear again later in the program. Also, the handouts and evaluations are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. If you're watching this program on demand and want to receive a social work continuing ed certificate, you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you're watching this program live, there's no social work test required. For social workers, if you're watching this program live, it qualifies for classroom hours. If you're watching on demand, it is considered non-classroom hours. Before we get started, I'd like to introduce our presenter today, James L. Sacco, consultant to the Alabama Department of Public Health. Welcome, Jim. Jim is no stranger to us here at Public Health. He's done quite a few presentations with us over the years, and he has a lot of important information to cover today. So let's go ahead and get started with our presentation. Welcome, Jim.
Bill, thank you very much. Thanks to everybody who's made time to be part of this. I'm really pleased to be here to have this conversation. One of the things that I am struck by is it's really hard at this point to say I've got evidence-based hard data on the impact of COVID-19 on substance users and individuals with opiate use disorder. I went back through the surveillance data, Alabama surveillance data, national surveillance data. We're not capturing behavioral risk. So as we try to look at cases and try to figure out what % of those people who are dealing with COVID-19 are individuals with substance use disorder, I've got no hard data. So what I do have is a whole lot of anecdotal report of an increase in anxiety and depression among all kinds of populations. And so my thinking today is this conversation is really important because as we're paying attention to what's happening as COVID evolves, as this thing, sort of natural disaster evolves, with the increase in anxiety, depression, other stressors, isolation, it's my belief that there's going to be an impact, and I think a disproportionate impact on individuals with substance use disorder and or opiate use disorder. And so I'm delighted to be here, and I think we're all finding our way. This is a topic, I think, where we're all sort of finding our way. As I think about those psychosocial stressors, what comes to my mind is kind of three-pronged, and they're here in the objectives. One, I think that probably people who are prone to misuse of substances are going to need extra attention and maybe some screening for substance use in a way that they wouldn't if COVID weren't here. I was on a webinar actually last week, and a participant in the chat box said, I've got a colleague who keeps joking that with all this time at home and all these Zoom meetings, I'm drinking more. And basically what she was saying is it was starting to take on an air that maybe it wasn't a joke. And so I just think about that because, again, as I think about populations I'm concerned about today, it's people that maybe were in normal range alcohol use or whose substance use wasn't problematic, but who with the additional stressors, again, of COVID, including isolation, for certain people, financial stressors, just the emotional stressors of what we're involved in, may push them. But secondly, I think for people that do have an active substance use disorder, the possibility that it gets worse, that people need additional support, people with opiate use disorder needing additional support, including access to clean needles, access to overdose reversal. And I guess the final thing that no one's talking about, that the population I'm concerned about, is what's the impact of people who are already in recovery from substance use disorder of COVID-19. It's my suspicion, even though there are a number of online tools available, but in many places, most places, people are not meeting face-to-face for their AA meetings, their NA meetings. And so in the absence of that support, again, coupled with psychosocial stressors, financial stressors, isolation, there's a part of me wondering if there's not underneath the surface risk for relapse for individuals in recovery, or if we aren't somehow having people relapsing into substance use who had been in recovery. Again, I can't find hard data to support any of this. I'm just sort of piecing together, and I'm inviting people who are part of this conversation, start thinking about where do we ask patients about their alcohol, drug use? Where do we get better at screening and referral to treatment? Where do we reach out to people who have been in recovery and offer a little additional support? Maybe from my perspective, it's just being able to say, you know, this is a really hard time. I know you've been sober 6 months, a year, a couple years. How are you coping with this stress? Are you able to go to any virtual meetings? Do you talk to anybody who you've been in recovery with? And just begin those questions. So those are the objectives there, understanding whether people are ready to change, how to do screening, linking people to support, and a bit about opiate use disorder. I want to start with a short COVID-19 update. We're here on Wednesday morning, and good news and bad news. I guess I just want to do the state of COVID-19. This data was CDC data as of last week. I didn't get data yesterday. So that's where we are. There were 32,000 new COVID-19 cases between June 14 and June 15. And so as much as I want to go out to a restaurant and go out honky-tonkin' as much as anybody, there's a clear message here that we see, particularly in the South and Western states, this increase in cases. And so there's your surveillance data, cumulative deaths at 119,000. On June 14th, 560 Americans died of COVID-19. Graphs in many places kind of slowing down. Graphs in, I think it's up to 23 states actually increasing. The worst increases, Oregon, Arizona, Oklahoma, Florida, South Carolina, Michigan, and Texas. Most of those places, with the exception of Oregon and Michigan, places that have relaxed their distancing guidance, relaxed their prevention measures. Again, we expected when people relaxed measures, there's been this push-pull. Everyone expected when measures were relaxed, there'd be an increased cases. There are a number of people who are seeing increases in certain southern and western states and saying it was too much too soon. And there's a conversation, I know in Florida, I know in Texas, I understand in parts of Alabama, to pull back on loosening up and going back to restriction. Number of stories in the last few days about Florida, the number of cases in Florida, and a tension again between opening up. Cases that are reporting lowered case rates, the 6 success stories down there again. To take the politics out of it, just largely places that have been locked down and stayed locked down longer than certain places in the South and West. Those are just the facts of places that are bending the curve. So we've got this increased opening up. You know, as I said, I certainly understand people's desire to get back to normal, desire to resume a normal life. But this tension of how to control the curve while opening up is something I don't have the answer to. I just want to name the problem. Huge increase in cases in the 4 countries listed there. Brazil, in terms of percentage increases is way ahead of anybody. Brazil is an enormous problem in Brazil. President of Brazil decided to ignore the problem, say it wasn't real, and not take any action. Enormous socioeconomic factors of people in crowded, unsanitary environments in the larger cities, just an explosion in Brazil. And certainly we know about our challenges in the States. Russia and India oversees the next, in terms of percentage increase, the next hotspot, global hotspots, according to the World Health Organization. I'm using the term COVID fatigue, and just as people prepare to go back to normal, number of stories of people, the bar is open, they went out to the bar, the tattoo parlor was open. Part of what I think this speaks to is human behavior, the sort of need to revert to what's familiar. I'm also thinking that part of this is about, we've been in fight or flight so long. There's some neurology to this. We've been so tense, many of us, for months, that the idea that when the all clear comes, or when certain restrictions are lifted, we feel a desire to act as if it's normal. It's actually the neurology of wanting to ease the fight or flight, using the prefrontal cortex to say, all right, I'm going to go ahead and relax, not be on guard, relax the tension and all that goes along with being in fight or flight. Again, we're getting some increases in reports of anxiety and depression. I'm hearing reports anecdotally, I'm not seeing anything in peer review journal yet, about increased intimate partner violence, IPV is intimate partner violence, and substance use. I stories about that, but again, no articles in peer review journals, because we aren't doing behavioral surveillance. We've just got kind of behavioral health providers independently sort of saying, here's what I'm saying. I look forward to peer review journals in which people do have a chance to cull together findings so that we've got a better snapshot of what the impact has been. We don't have that now. Again, decreases in parts of the United States, increases in the South and rural areas, including places with food processing. One of the things you'll see if you look at the surveillance data is pockets of disease in small Midwest, small North Carolina, big pockets that emerge. There's a meat processing plant in South Dakota. One county had 900 cases. They had to close the plant down. And again, what happens if you look at these hotspot counties, often in rural areas, they are linked to, again, places with close quarters, poor sanitation, people who, the way you work in a particularly meat processing, people are very close to one another. There isn't a chance for social distancing. And so these spikes related to food processing. What that means is an impact on people of color. Two things. That's about access to health care. That's also about just the social determinants of health, that if we look at who's not surviving many chronic health problems, we see poorer outcomes because of the social determinants, access to care, access to resources among people of color. And there's a real alarm. I just saw some supplemental funding go to Morehouse School of Medicine. Seems like several $100 million to take the lead on addressing this disproportionate impact of COVID-19. But if you look at most states and you look at percent of the population that's died from COVID and percent that is African American or Latinx, there's a significant disproportionate impact on people of color. And the last reminder down there from the talk I did 2 weeks ago, our highest death rates continue to be among older Americans. 80% of deaths happen in people 65 and over. So again, we're moving towards 2.5 million cases all across the age spectrum. If we go back to those deaths from COVID, what we see. So we're going to try to keep this interactive. Bill said there's question, comment. I've said many times I'm missing the classroom and being able to visit with people and have Q&A. So I'm going to stop several times. You've got the option to call. There's the ADPH, or the Alabama Public Health Training Network, and some of you on Facebook Live. If you're on Facebook, there's an option for that. Bill, any questions yet? Any comment yet?
Sorry, Jim, having trouble with the mute. No questions yet, but I would agree that here in Alabama, we're seeing a lot of the same things that you talked about, a lot of the similarities as well. Rural areas have been even higher numbers, per capita, and so I definitely would agree with all of the things that you've said there. We've also got a variety of meat packing type companies around the state where we've had some outbreaks, and of course we continue to have some of the issues with our elderly in different parts of the state as well. So, and our numbers are starting to go down a little bit, but that's because they've been so high over the last 2 weeks. So.
All right. Thank you, Bill. Again, if folks have comment or questions, please, we're monitoring email, we're monitoring the phones, we're monitoring Facebook Live. So I use the term social determinants of health. Basically, we could do a whole workshop on that. But what I'm referring to is the conditions in an individual's social and environmental interpersonal factors that affect health. And so if you look there, this is a Kaiser Foundation graphic that just kind of says, here's what needs to come together. If you've got economic stability, good access to health care, cohesion in a community, those factors increase social determinants, increase the likelihood of people living well. Where those factors are limited: poor economics, poor education, poor access to healthcare, neighborhoods that aren't conducive, those negatively impact. There's an article in the Journal of the American Medical Association. Again, this was the first week of June. Dr. Clarence Yancey is a cardiologist at Northwestern Medical, and he wrote the editorial. Again, I think it was the first week of June in Journal AMA. But what he said about, basically, he was looking at the impact on people of color and the disproportionate impact on people with poor social determinants, and he made the point that it's not acceptable. So he talked about this surveillance data, but what he also said, I think, is humbling to me, to all of us, being able to maintain social distance and get a paycheck while we're working from home, or getting a furlough and getting whatever else, and debating what to watch on Netflix, are issues of privilege, is what he says. In certain communities, that's not their reality. In other words, if I've got to make money for my family at a meat processing plant, knowing there's no sick leave, there's no opportunity. If I've got hungry people back in the country that I have immigrated from, and they're waiting on a check from me, the ability to stay home and watch Netflix is not there. And so the aggregate burden is what he says, of higher comorbidities. More likely people of color have had poorly managed cardiovascular, COPD, other risk factors, the adverse social determinants, and the absence of privilege coming together. And later in the editorial, he says we as a culture have to decide if this situation is acceptable or not. So again, I just think as I look at the epidemic unfolding in disproportionate ways with people who are socially disenfranchised, and I know we've got social workers on the call, social workers call to arms. What's our role in terms of turning that around? Good news, I've got a non-update. The way you avoid COVID-19 continues to be the same. Those issues there, hand washing, physical distance, mask when you're out in public, limiting social contact. CDC is still saying fewer than 10, gatherings of fewer than 10. An interesting articles have come out about risk being lower when you're out of doors. And so as we certainly, I want people to maintain physical distancing, but I've read several articles, including one by a former director of CDC, where he talked about how inefficient transmission, even without a mask, is if you are out of doors. So again, I'm going to say fewer than 10 people maintain at least 6 feet, but it appears as they rank, there's a number of articles that rank relative risk, and being indoors in a concert or bar with screaming people, nobody in a mask comes up as a 9, the highest risk. Being 10 feet away from people with your mask outdoors tends to be a 1 and the lowest risk. So, you know, part of what I think we're all learning to live with is what level of risk we're willing to live with. Early on, I had a friend who said he was going to stay home for as long as he was vaccinated. He wasn't going to go anywhere, get his groceries delivered. You know, if a vaccine is a couple years away, who can stay home indefinitely and have groceries delivered? So I think for many of us, we're going to kind of have to tease out what level of risk and make educated decisions about level of risk we're willing to take while following good public health guidance. I think it's critical that we look to the CDC to give us the best science they've got about how we avoid contracting and transmitting COVID-19. So more specifically about substance use disorder, opiate use disorder, there's a definition there. What I like about this, SAMSA definition, what I like is that it talks about use that's linked to impairment. One of the things that early in my career I used to do, we used to get really caught up in substance use history, where you counted the number of beers and the number of joints and the number of pills, and it was all this trying to quantify problematic substance use. And what I like, and increasingly progressive models kind of say, let's look at the impact the use of substances or opiates are having on people's ability to work and school and relationship and finance. So now in my grown-up social work practice, I'm listening for, have you had any legal trouble? How's it affected your employment? How's it affected your relationship functioning? How does it affect your day-to-day living? And that those questions and yes answers on those tend to be ways I say this person may have problematic substance use. And again, there's your opiate use disorder also from SAMSA. So SAMSA, I'm using that term like everybody knows, Substance Abuse Mental Health Services Administration, the arm of the federal government that advises us on substance use prevention and treatment. SAMSA put out a white paper sometime in early April that just kind of talked about issues for substance users in the age of COVID. They talked about physical vulnerability. This SAMSA white paper, it's available, samsa.gov. There's a link there that says COVID-19. They still have that on the website. I looked last week when I finished these slides. So smokers and vapors are having increased vulnerability because of the respiratory problems associated with COVID-19. So it makes sense that there's more susceptible, and that illnesses, if I'm already doing stuff that is hard on my lungs and I get a virus that for, I think, almost 2/3 of people, 70%, have respiratory symptoms, and those respiratory symptoms emerge, it's going to hit me harder and longer and probably more lethality. It seems that opiate use and methamphetamine use increase the severity of COVID-19 disease. Again, I think you could argue the way in which those substances are used, the physical distancing that's not practiced among some individuals who are using meth and opiate use, and just the disinhibiting effect, particularly of methamphetamine, making good decisions about social distancing and prevention measures difficult. The last bullet here, I think, is just speaking to reality. It's hard enough for people to get care. I know it seems like the health system, if you've got any symptoms that sound like COVID, the system's saying, wait a minute, stay at home, we're not sure we want you to come in. And obviously there's some safety factors, but this last bullet just kind of reminds us that as hard as it is to be seen in a practice where you say, I've got symptoms of COVID, what SAMSA argues in the white paper that I'm referencing is try to call and say, oh, I've got an active substance use disorder, and by the way, I've got symptoms of COVID, and I'd love to drive over to your clinic. As much as I wish I could say the stigma of substance use is behind us, the fact that that stigma still exists, sort of coupled with risk of or symptoms of COVID-19 makes access to health care very difficult. So physical vulnerability to COVID, again, making this connection between vulnerability for substance users, COPD, cardiovascular disease, more frequent among chronic smokers and people with substance use disorder are going to worsen the prognosis. So like everybody with chronic health problems, again, the reason the elderly are disproportionately being impacted is the prevalence of these pre-existing, pre-morbid physiological conditions increase the severity and the mortality. I think what's also important, and again, as I think about my suspicions about why screening for substance use, prevention of substance abuse, prevention of relapse is so important, I think there's an enormous set of psychosocial factors that are coming into play for everybody in the country. Grief and depression, anxiety, and the uncertainty of transmission, of living in this age. Physical distancing, a safe thing, but also the feelings of isolation that many of us are experiencing. We talked, if you were on the webinar 2 weeks ago, and I talked about seniors, I talked about the importance of protecting older Americans from contact and the isolation that can accompany that if we're not creative. The last bullet here, again, these are straight out of the SAMSA white paper that I'm referencing, talked about if consumers with substance use disorder at risk have an existing history of trauma, of a traumatic past. That is, they bring adverse childhood experiences or childhood trauma into their adult functioning. The article made the point that the impact of COVID-19 may be that much more severe with individuals who have, again, childhood trauma, adverse childhood experiences. I'm starting to wonder out loud if when we think about COVID-19, we don't need to think about it, comparing this to a natural disaster, and that like a hurricane, like a tornado, like an earthquake, like a mudslide, that maybe the impact of this natural disaster for some individuals, particularly individuals with pre-existing vulnerability or poor coping mechanisms, may result in increased symptoms that look like trauma. I don't know that. I think it's up to all of us to start paying attention to whether or not the impact for people with a more significant substance use history, trauma history, is there. So thoughts about substance use. As I said, it may be the case that with the increased suspicion, I go back to the chat box in my webinar last week. The person said, I'm worried about my coworker who's joking a lot about, boy, I really have to hammer down some wine after all those Zoom calls. Some guidance on how to have that conversation. I think you suspect substance use. I think what's really important is to recognize if there is a problem, I probably have my radar up expecting judgment because of the stigma I talked about, thinking that substance use happens to bad people somehow. I'm already a little on guard. So being really mindful that as you begin a conversation, you try to do what you can to say, I hope you don't mind. I'd like to talk to you about something. I think the most important thing is that doesn't convey judgment if you say, because I'm concerned about you, I want to ask you some questions. The opposite of coming from a place of judgment is I'm concerned and I want to understand your use of alcohol, your use of substances, and whether or not it's increasing or problematic. Again, as you're taking a patient history in a social work setting, in a medical setting, always listening for employment changes. Obviously, in the age of COVID, we've got people changing, being furloughed, changing employment, losing jobs. But is there any connection between employment changes and substance use? Any relationship breakups? Any people relocating? Again, we got to ferret out if there's circumstances related to COVID, or again, if any of these factors might be related to an increase or more problematic use of drugs and alcohol. People in medical settings, sleep habit, weight, mood, overall enjoyment, those changes can be flags of substance use or opiate use disorder. And so just kind of being mindful to sort of say, hey, can we talk about those things? And again, particularly to opiate use disorder, any sort of misuse of substances, looking for refills, seeking substances. Most of us now are in states where there's a prescription drug monitoring program. So the flag comes up, we filled this person's Vicodin prescription 20 days ago. No, they're not due for a refill. And so there are systems in place, most places, that are going to flag substance seeking. But again, all these clues are ways for us to have a conversation. Again, listen for these problems. Consider, do you want to engage significant others? Do you want to say, hey, I'd like to talk to you about this? Do you want to, could we bring in your wife, your friends to talk about that? The last reminder, I think, is the dance of shining a light on substance misuse is you want to make sure you keep that relationship open. So when somebody says, I'm not talking about my alcohol use, you need to stop talking about my pain medication. I'm in real pain and you don't understand what it's like. There's a common one with OUD. I think rather than getting in a fighting match, you need to just say, all right, I'm going to trust this person. I'm going to keep that relationship intact, and I'm going to honor what my client's telling me. I'd love to hear what people have found helpful. This is another opportunity. I'm going to put this slide up in another 7 or 8 minutes. Bill's going to read suggestions, but at this point, I'm really listening for suggestions. What have you found helpful in your practice? Screening, intervening, making referral. Again, you've got somebody suspected of substance use, needs behavioral health. What have you found helpful in terms of your own clinical practice? And again, if you would, let's call those best practices. One thing we do that works, one thing I've found that will be helpful. If you can give me those suggestions, I'm going to ramble on another 6 or 8 slides, and then Bill's going to read any intervention recommendations that you've got. If you're able to do that, it's extraordinarily helpful. And I think I'd love to hear lessons from the field. Bill, let me catch my breath. Any questions I need to address or comments so far?
We have actually had a couple of questions, and I think they go back to the some of the early things you were talking about. And you talked about AA meetings, NA meetings not happening during this COVID time. Everybody is working from home, staying at home, those kinds of things. And have you seen widespread use of Zoom meetings for AA and NA
Absolutely.
meetings?
Absolutely. Yeah. Let me clarify. There are not many in-person meetings happening, most places for social distancing, but there are a number of online options, both national, statewide. The way to find that always is go to the white pages in the phone book. Every community in the world has AA. Most have NA listed in the white pages. Just say, where do you go for virtual meetings? If you Google virtual AA, I had a former client give me 6 different recommendations for on a given day where she goes for virtual 12-step support. So it's out there, but it's different than what I know. And that was the point I was making. And thanks for clarifying that. If I go to First Presbyterian on Tuesday and I see Betty and Bob and we go out for coffee at Waffle House afterwards, and that's my support network, there is support available. It's just different. And I got to work harder. And it's different, but yeah, there's online, lots of online available. Again, every community has AA, Al-Anon, Narcotics Anonymous, hotline. Where can I find a virtual meeting is a question that you can link your patients to a virtual meeting.
And you mentioned a hotline there. Here in Alabama, we have our quit line for tobacco, for tobacco cessation. Are there similar resources for maybe drug use or different types of drug substance abuse?
Let's add that to our best practice question, Bill.
Okay.
Let's go ahead and put that out to our experts. Anybody that knows good 800 lines. What I have in a later slide, Bill, is a statewide overdose prevention phone line in Alabama. So I'll give you that shortly. But sure. Everybody, if you know of good resources, web-based phone resources, that would be super helpful for linking people to services.
Okay. I think that's all the questions I have at the moment. You did talk a little bit about grief resources, and I know we'll probably talk about that a little bit later, but and we talked about that a couple of weeks ago as well. But I know there's a lot of funding that's been coming out of Washington over the last few months related to COVID, and so a lot of these funding sources are helping different either both nonprofits and other substance abuse agencies and whatnot. So I don't know if there's anything you're familiar with, but
I don't know where it's landed, Bill, but you're absolutely right. The good news about what's happened in the CARES Act is there's an enormous amount of resource for social services that's in process. I just saw something in the last month that was awarded. It was six figures. It was several $100 million in 30 or 40 communities to increase behavioral health services. And so we see, I think we can look forward to that, where those will be and exactly, anytime the government moves money that fast, they move the money, but how to hire people, set up services, as you know, is the next level. So,
yes,
Bill,
definitely.
thank you.
Yeah, we're working on that here, even at the Department of Public Health. There's funding sources coming our way, but it does take a minute, to get things in place, get people hired, get programs started,
Yeah.
or at least get them, expanded. So,
yeah.
Anyway, thank you, Jim.
In process, but good news, bad news. Bad news, we've got an enormous wave of behavioral health need. Good news, I hope we're going to see new resources to help address that. I've used the term substance use screening. I just want to give people some tools there. CAGE is the oldest one. I learned this when I was a young social worker 100 years ago. Again, when I talk about screening is really you just want to get to a yes or no answer. Does this person need to be referred on to somebody with more extensive substance use training to sort of tease out if the use is problematic? So this is a tool we teach people in primary care. Again, just as part of that routine physical, have you cut back? And if you get a yes answer, a referral to somebody in behavioral health who can help you. If you try to cut back, do you get annoyed when people inquire? Do you ever feel guilty about your use? Do you ever need an eye opener? Do you ever need alcohol, substances to get your day started? I'm going to talk about a model, a model for sort of integrating substance use conversations in primary care for people that aren't necessarily trained specifically in behavioral health. But SBIRT, the substance use brief intervention, is something we're going to play with today. The SBIRT questions to kind of get the conversation started. Again, you tried to cut back. The second, pre-screening for SBIRT, and another kind of way to begin the conversation. Have you used substances more than you intended? An important hallmark of problematic substance use is I went out to the club and I said, tonight I am not going to get drunk. Tonight I'm going to have 2 beers and get home at 10 o'clock. And lo and behold, I had my first 2 beers. The music was good. The honky tonkin was fun. And instead of 2 beers and going home sober at 11, it was 3 in the morning. I staggered home, or worse yet, for other reasons, I staggered to somebody else's house, not sure who they were, not sure how I got there. And there you have it. So I talked about SBIRT a minute ago. This dates back to the early 90s. This model, again, all this is available through the SBIRT manual. There's online training available. Basically, it's a brief conversation in healthcare settings or other social work settings. So again, this is not for people that are doing addiction treatment. This is, we are a generic social service agency. We're doing other kinds of behavioral health or social service. We are a primary care. We're a pediatric, probably not pediatric. We're an internal medicine practice, and we want to know about and respond to what we think is suspected substance use. This model has been around again for, you see, there more than 30 years. SAMSA hit on this early on. Model simultaneously evolved in the United States and Western Europe. Kind of the idea here is we're screening for problematic use, and what's important there is we're not diagnosing anybody with substance use disorder. We're just saying, you know what, this use is problematic enough. So you've got these screening questions that allow you to say, this is problematic. It merits further conversation. That's the point. And so there were early efforts, brief advice. The current approach, the early efforts in the early model was sort of, here's what we almost a diagnose and prescribe. Here's the screening results. We think you should go talk to somebody. The updated approach to SBIRT uses motivational interviewing, a counseling technique. Rather than prescribing what you should do, you use this set of skills to motivate consumers to have follow-up conversations about their substance use, building on their own perception, their own reasons to change. So the process is you have routine screening. Most people screen negative, so you ask questions about substance use. Here's the good news: it's 2 or 3 minutes. Everybody says, "Oh, I don't have time in healthcare." Well, can you take 2 minutes to find people who have undiagnosed problematic substance use? That's really what we're talking about here. So this screening happens, and then a brief intervention adds 5 to 20 minutes, but it says, I want to provide feedback. Here's normal range drinking. Is for women no more than 7 standard drinks. For gentlemen, no more than 14 standard drinks a week. No more than 2 ounces of alcohol at any given instance. And then you're sort of focused on there's the facts. What do you think about it? Are you willing to talk to somebody about it? The goal of brief intervention is to connect the dots. Here's what's the finding on your screening. Here's what that could mean. And then the intervention is, can you make a referral to treatment? Again, brief intervention and referral to treatment. Again, you're not diagnosing somebody with addiction or alcoholism. You just say, I want to send you a substance use professional who can help you ferret this out. Again, most people are not going to need a referral to substance use assessment, about 5%. So again, these are general population figures. 85% going to screen negative, 15% maybe problematic. In truth, about 5% of people who are screened need a referral for follow-up. Again, not for drug and alcohol treatment, but to someone that can help do a more thorough assessment than we can in primary care. So these are the goals of brief intervention. What does a patient think about their use? We want to give people feedback. And then again, these last 2 are critical. We want to increase somebody's motivation, like help them figure out how their life could be better, how certain problems they are experiencing could be alleviated if they shined a light on their use of alcohol or other drugs. And then again, offering a recommendation. We'd love for you to go talk to someone is the best advice. But then negotiating the goal, sort of saying, what do you think about it? Some cautions here that nobody ever wins this battle by coming off. I always say, like Rambo, sort of, you don't want to set yourself up in this conversation about screening like you're a law enforcement agent. Or you don't want to go on the Jerry Springer show with people throwing chairs at each other and having to be separated, pulling each other's hair. Guilt and shame are never helpful. Guilt and shame are always harmful, always harmful. And so anytime someone's tempted, what kind of mother would use the grocery money for their children? You need to catch yourself because those interventions always cause harm. Any intervention that gives you sustained talk, which is shorthand for saying the patient is arguing, I don't need to, I don't want to, I don't have to. One of the things cliches in motivational interviewing, there's going to be ambivalence here. Ask yourself as you're having these conversations, am I dancing with this patient's ambivalence about their substance use, or am I wrestling with this patient? And the takeaway is, I don't know, anybody can win a wrestling match with somebody about substance use disorder. Somebody who's ready to change is someone that has been allowed their ambivalence and finds their own reason to change. So as we think about the goal of brief intervention, and again, as these issues come up in healthcare, sort of, can we talk about cutting back? Can we talk about when you start using? Could you start later in the day? Do you have access to supplies? What do you know about overdose reversal? One of the things Bill and I were talking about before this went live is early on, as people locked down, as services were less accessible, an increase in opiate overdose. And again, hopefully as things open up, as systems get more creative, we are seeing, we should hope to see a decrease in these increases. But anytime you're talking to someone about their opiate use, the conversation has to include overdose reversal. Like we're talking about Vicodin, we're also have to be talking about what do you know about how people who overdose have access to tools that can save them from dying if there's an overdose. We're talking about saving people's lives here. And other harm reduction steps combining. And I always like the idea of talking about a small step or baby step. I'm not going to give up drugs completely. I'm not going to give up alcohol completely, but maybe I can cut back. Maybe I can hear you when you talk about a small step. When you're making referrals, I think it's important that you figure out if somebody's ever attempted or succeeded at treatment in the past. Ask permission, then offer options, 12-step groups, outpatient treatments, intensive outpatient. Again, we've got treatment largely going online still. I think most treatment facilities that I'm aware of are practicing virtual substance use treatment. And you'll see in a minute, residential inpatient treatment, very, very restricted and only according to SAMSA guidance in the most severe. So you've made these recommendations, you ask your patient, what do you think about those possible referrals? And then you take the next step following their lead. If they're saying, let me think about it, I'm not going to no treatment, I'm not going to any AA meeting, it doesn't help to argue with someone at this point. You've planted a seed. What I always say is at this point, you've planted a seed. You shine a light on the problem, you name the problem, and you invite people to continue the conversation with you. Again, early on, as part of the SAMSA guidance, they suggest in the guidance document that I've referenced before that outpatient only be used with the most seriously mentally ill. And the example they gave, someone's actively suicidal and depressed. But beyond that, the very few inpatient psychiatric settings that are operating are looking for someone who absolutely cannot be sustained in the outside. This is from the SAMSA white paper that I've referenced earlier. I was really surprised that they were this frank, but there is, according to SAMSA, no evidence that residential treatment outcomes are better than intense outpatient treatment. I say this because if I were an entrepreneur running an outpatient treatment facility, I'd be glad to see this. If I were, a hospital-based residential treatment program that touted how your brother-in-law should come to me for treatment, SAMSA evidence, and for third-party payers, do they want to pay $35,000 or probably a quarter of that for outpatient treatment? Again, clear guidance from SAMSA in this April paper where they said there's no difference in outcomes and the implications of that. So lots of telehealth in these challenging times. Most people are going to use it. I think if you are using telehealth, making sure you're using HIPAA compliant tools, people using Zoom and Doxy, a lot of Zoom, a lot of Doxy. Again, work with your legal and your supervisors on what's helpful. But again, I've probably done a dozen webinars since the epidemic began. Vast majority of behavioral health is practicing telehealth, and there are some people that argue there are advantages to telehealth. I think there's some people who would argue maybe patients can be more honest when they're not face to face with us. It's accessible anywhere. Patients don't have to get up, get dressed, get to a thing. And I think there are certainly some challenges learning to modify our practice to a telehealth environment. I'm going to catch my breath. Bill, I asked you to poll our experts and ask them what they see and what they found successful. What have you heard in terms of suggestions?
Jim, we did have a message that said, I found the expert model to be very helpful in their practice. And that's something that we've been able to do here in public health, is we actually partnered with the University of Alabama a couple of years ago with an expert program, and that continues to go on. We've done a lot of training with that in specific counties, hoping to maybe be able to expand that in the future. So we did have some feedback that said that they really found the expert model to be very helpful.
Again, we're talking about so much untreated substance use, and you say, can everybody in primary care settings, other health settings, take 2 minutes and do the screening questions? I think there's a real argument. If we're going to catch that any percent of that 5% people with undiagnosed substance use and refer them on to treatment, I think it makes great sense. So I want to talk a little bit about, Bill, is there more comment?
Well, I did have a couple of comments. What about dual diagnosis? And you see individuals with dual diagnosis, and you think that maybe the inpatient facilities, I don't know, I'm just kind of asking your thoughts there related to those that are dealing with, more than just one thing.
Sure. Yeah. I think if you look at the findings, Bill, I just did a talk last week on specifically on this, and talking about behavioral health and primary care. That was the topic. But if you look at pre-existing mental health, most people say with substance use disorder, it's upwards of 60-70% have another underlying behavioral health disorder. And so this connection, absolutely. A vast majority of that is depression. It shows up as depression. I also think what we're seeing, and based on my own clinical practice, I also think what we're seeing is a whole lot of trauma. That if you've got people who've experienced adverse childhood experiences, childhood trauma, the prevalence of substance use disorder is extraordinary. I have been around enough substance use treatment. I know a number of treatment facilities, particularly for women, who say, we just assume that every woman here is a trauma survivor, and include trauma techniques, trauma training for their staff. I'd be hard pressed to argue against that, Bill. Even if prevalence is 70 or 80%, you got a majority. It's certainly high for males. Again, most people would say prevalence of trauma for females with substance use disorder is off the chart. And so the people I respect just say you've got to be trained in trauma to do substance use treatment with women, and including that as part of outpatient treatment or inpatient treatment. Again, I think that probably when you think about people who are more likely to need inpatient substance use treatment, probably people with more severe depression, where there's a risk of suicide. We also know substance use is an enormous factor. I want to say of people that succeeded, 40 to 50% of people that succeed at suicide are impaired at the time of that attempt. And so this connection between substance use and suicidality is also there. So if I don't have hard data, Bill, but if I was guessing where we want to consider substance, I would say substance use disorder plus serious long-standing depression, certainly plus any instances of trauma. Those are people where evaluating, even in the current time, whether for safety reasons that person doesn't need hospitalization, inpatient hospitalization.
Jim, and again, I don't have any hard data either, but I just know from personal experience, from work experience, that for March and April, things kind of quieted down. We didn't have the calls that we were having, but then May and June the phones are back off the hook. I guess they were calling about COVID issues in March and April, but now it's back to the social issues, the issues that we normally see with social work and public health. So one of the things that I recall in March, the Alabama Board of Beverage Control, they had $6 million more in sales in the month of March than the previous years. And so I think everybody was kind of stocking up on their beverages at the time. And then I also learned and heard that there were access to different types of drugs were just not as readily available on the streets during March and April, but now we're starting to see availability again, and so folks are starting to get back into, I guess, what would be their normal drug of choice. I also was hearing and reading that, you know, since the access of those drugs weren't available, that they were using other substances, maybe substituting some over-the-counter or type medications or prescription medications, and so that was a big thing that we saw, you know, recently.
Yeah. Thank you. Yeah. No, I mean, I think you're absolutely right. If I'm again, you've got some data on beverage sales. Were we all just making sure we had enough wine for supper? I suspect there was some of that sort of pre-planning. And also, as I said at 9 o'clock, I just think that all this psychosocial stress is leading to an increase in substance use. And you're right. If I'm an active substance user, I'm going to use whatever I can to get high. And certainly what we know is as access to prescription drugs gets harder, as we get better about clamping down on synthetic opiates, we've got people all over Alabama, all over the country, who didn't ever dream they'd be heroin users. But I can't get the drug that I was getting from my doctor, and my nephew says he's got access to somebody over in East Tennessee can drive up and pick us up something that will help me feel better. And anywhere we see synthetic opiate use, and I talk about East Tennessee, North Alabama, because we know those overdose counties all along the Appalachian Trail are highest risk for drug overdose. What that says to me is a bunch of those people have graduated from prescription drugs to heroin. So I want to talk a bit about injectors, because I do think as we sort of think about the needs, there are some unique needs. Again, I'm here in Asheville, North Carolina. At one point in March, we were operating the only syringe service program that was open in 7 states. And so what they tell me at WinCap, Western North Carolina AIDS Project, is they had people driving from all over 7 states. I guess that's Tennessee, Alabama, Georgia, South Carolina, North Carolina, probably Virginia, I reckon. But 7 states were coming here to get clean needles. And I mean, I think good that people were coming here. And many syringe programs have opened back up that had closed. But part of what that speaks to, again, to your point, Bill, is if I'm a drug injector, COVID or not, I'm gonna need access to drug if I can get it. And if I can get, I'm going to need access to needles. And again, thank heavens that there was a program open. And again, here in Asheville, town of 100,000 people, the needle exchange program that I'm referencing, previous years, pre-COVID, averaged 500,000 needles a year. They're distributing 500,000 sterile syringes a year here in Asheville. And I know, because I volunteered there, that people are actively driving an hour or two to get clean needles from here. So anyway, vulnerability of opiate users because of other medical conditions. Again, as opiate users age, and we're talking about people who started on synthetic opiates and graduated to other opiate use, we're also talking about old school kind of people that have been using heroin, been using opiates for a while. Those older users have other pre-existing medical conditions, like other people of a certain age, that increase their vulnerability. I talked earlier about places in which drugs are used, and I was just thinking specifically of places where people inject in a social network, particularly meth use, sometimes heroin use, but where people are congregating. If there's a shooting gallery or an abandoned house where we meet to share, though there isn't social distancing in places where drug use is happening. Sharing equipment obviously is problematic around issues of COVID, but much more around other infectious disease. The stigma of being an injector, of having opiate use, and certainly of being a person who injects drugs, is something that makes access to healthcare problematic. I talked earlier about being someone with substance use and how, let's be frank, the system really isn't crazy about treating substance users. And if you make that first call to a healthcare provider and say, oh, by the way, I'm an active drug injector, but I'd like to come for primary care, whatever the service is, you're going to, I think, encounter some stigma and reluctance to treat, depending on how providers that have been there. The other thing I reference in particular is as outreach activity, other activity to drug injectors, the access to overdose reversal and fentanyl strips. Just to be clear, what's killing opiate users is fentanyl, heroin that's laced with fentanyl, and drug users that are mindful about that, there are strips that allow me to test for presence of fentanyl in my drug before I inject, so that I can minimize the possibility of a drug overdose by testing for how much fentanyl. So wonderful national organization, the Harm Reduction Coalition, that provides all kind of support services, training. If you want any more information about the needs of drug injectors, the Harm Reduction Coalition is at harmreduction.org. Their advice, again, like everybody, there's a page, sort of advice in the age of COVID, caution about sharing supplies, doing what people can to stock up on supplies so they're limiting interaction with others in the age of COVID, trying to have less contact. Preparing drugs yourself rather than being in this kind of communal drug preparation, drug injecting makes good sense. Planning ahead and stocking up on Narcan or the tools that are going to allow for overdose reversal, stocking up on fentanyl strips in advance. So in other words, if you're working with people who inject, again, particularly if they're in places where social distancing has made access to services harder, just sort of can you keep a stack of needles? How can you keep a stack of Narcan? How can you keep a supply of drugs? Fewer. If you just substitute potato chips, which is my drug of choice for that last one, if I stock up on potato chips, I'm less likely to contract COVID because I've got my stash there in the pantry. Again, if the drug of choice is not potato chips, but something else, stocking up on that drug just means less social interaction, less risk of COVID, less risk of contracting or exposing someone else to COVID. What we know is that there have been challenges, but most medication-assisted therapy has continued. When I talk about MAT, I'm talking about the 3 medications there and the fact that they are the first line of treatment. Sometime last year, I worked with the Alabama Department of Public Health on an opiate use disorder webinar, and the guidance is really clear that there's a role for abstinence-based conversations, there's a role for other kinds of counseling models, but that the evidence base for MAT in responding to someone with opiate use disorder is not refuted. And again, because of the changes in brain chemistry, using these medications to minimize craving, allow me to get into recovery are, I think, essential for most people with opiate use disorder. As part of that conversation last year with ADPH, there are a number of certified MAT programs. The Alabama received a significant, Bill and I were trying to tease out the amount of money, a significant amount of money to allow Medicaid recipients and people without the ability to pay access to medication-assisted therapy. And these 21 counties in Alabama have certified programs where access to MAT is available regardless of someone's ability to pay. So Bill, here's your resources here again on MAT, and I'll listen to see if our experts have any other resources for us. It's a wonderful program. I think it's based in Huntsville in Alabama, state of Alabama. Obviously they've got other resources, but in Alabama, notonemorealabama.org. This is a group of people who have been affected by opiate overdose and are doing something about it. It wasn't clear in the story. My hunch, as I looked at the website, looked at the work they're doing, was that probably these are a number of parents who've lost children to opiate use disorder who wanted to make a difference. And the work they're doing, from what I could tell on the website, looked extraordinary. So access to overdose reversal and SAMSA resources on medication-assisted treatment there for you. Bill, I'm listening for any other resources our experts have. Have you gotten anything on the website or on the Facebook that you can share?
I have not gotten anything related to resources, but I do want to mention, you mentioned their training from last year. It's still available on our website. If you go to our distance learning section, you can find that training and get some additional information from it. So it's still very relevant information. If you're interested, please go look for that. I do want to ask a couple of questions, though, to you, Jim. And so because we're doing this Facebook Live and we're kind of reaching out a little further during this COVID-19 to people that maybe are watching this and following this, how do you explain handing out needles to users? It's almost like you're encouraging them to use. So what's the thought there?
Sure, absolutely. Thank you, Bill. So let's talk. That's absolutely the criticism that if in fact we give people access to clean needles, that it is giving permission. What I say to people, Bill, is all of us want people with addiction to find treatment and find recovery. So let's start there. And good treatment programs that are offering syringe, again, the language is syringe services program, are making syringes available with the primary goal of preventing disease. And I think that's where we need to start. The reality is the bloodborne infections, hepatitis B, hepatitis C, and HIV are all preventable if people use a clean syringe. And so I think what happens, Bill, is from a public health perspective, you weigh the disease prevention benefit and the cost. The other issue you're raising is there any increase in use as a result of access to clean syringes? And the data is pretty compelling. There's no, people who inject are going to inject. So what happens if we're giving people clean syringes, the same percent of people are going to inject, but they'll inject with clean syringes. And the rates of hepatitis and HIV will decrease. The other argument in favor of syringe programs is we have people there for a minute, for however long they're there, and we could say, ask about other needs. We offer HIV screening, hepatitis screening here. We can link you to hepatitis C treatment. Hepatitis C, just so we're all on the same page, is now curable. What has been a potentially fatal health problem is now treatable if we screen people for Hep C and treat them. Hepatitis B is vaccine preventable. So if we're in these conversations about syringes, what should be happening is we should be talking about disease prevention, disease screening, vaccination for hepatitis B. And we should also be talking about access to treatment, that most syringe programs are comprehensive, give people who are injecting the opportunity to access drug treatment and know about drug treatment. And so yes, again, Bill, I think what I'd say to our Facebook users is we all want people who are problem users to abstain. The question becomes, what's best for those individuals who are injecting today? And I would argue what's best for the public health good. From my perspective, there's very clear evidence that comprehensive syringe service programs are, again, saving lives, preventing infectious disease, and offering an opportunity for people to access treatment and other supportive services who wouldn't have those if syringe programs weren't. So like everything in public health, we're talking about cost. and benefit, I think there's pretty clear consensus. And again, the data is really clear that if I need a needle today, I'm going to use a needle. And so it's just a question of, do I use my cousin's needle? Do I keep reusing my own needle? Or do I have access to clean needles? So the argument in particular that we're increasing needle use, the same number of people are going to inject today as injected yesterday. It's just a question of how many are going to have access to a clean needle.
Thank you for that information, Jim. I know that there's been a bill before our legislature here in Alabama the last couple of years, and I think it had actually been making a little headway before the COVID-19 outbreak. And so, obviously everything kind of shut down at the legislature. And so maybe it'll continue to get some positive feedback there in the legislature, and we'll see that in the near future. The other thing,
Bill, if I could, Bill, let me just say that there's been a change at the federal government level. CDC now lists on their website as an approved effective intervention distribution of clean needles and comprehensive syringe services programs. So I know there are places that are still coming around, but if we talk about CDC as the premier agency to prevent communicable disease, CDC's HIV website now lists a number of interventions that will that they call effective interventions that they support to reduce HIV transmission, and syringe service programs is now listed as an effective intervention on the CDC website. Let me talk, Bill, just real quickly about relapse prevention. I said as we're sort of trying to figure out what, I think in a year, in 2 years, in 5 years, we'll say, here's what happened. Here's what happened during COVID-19. This is one in particular because we're not capturing data on individuals' behavioral patterns before they get COVID-19, sort of how people who were in recovery have been affected. But what I can say is these are the psychosocial issues that I showed you in a previous slide, that these things all are at work in all of our lives and in the lives of people I'm concerned about who are living with substance use disorder and people who are in recovery. So I wanted to end by just kind of talking about how people cope with grief. If you are in a setting where you're working with people in recovery, people vulnerable, people who are increasing their substance use, I think these strategies for ways to deal with grief are important. The most important is feel your feelings and get support. The way I was having a conversation with a friend of mine sometime last week. She was real critical of herself, like, I just can't get things done, and I'm just, what kind of mom am I? What kind of employee am I? She was really down on herself. And I said, Evelyn, we're all grieving. We're all in a kind of collective grief. And she sort of, we were on a Zoom so I could see her. And I said, there are a lot of therapists who talk about a kind of collective grief, other mental health providers who are trying to help us understand what's going on, and they're calling it grief. And I think, sadness, bargaining, anger, the cognitive stuff that can be part of a grief reaction, all those feelings are coming up. So sort of naming that, talking about how unique the grief process is, how unpredictable the grief process is. And then the way people cope with times of grief successfully is they get support, they develop self-care plans. This last bullet is critical as you're working with people who are expressing symptoms consistent with grief, sort of doing this differential diagnosis. If you're a social worker, behavioral health person, you have the skills. Otherwise, you may need to invite somebody into a conversation. There's a difference between grief, which is temporary, linked to a specific event, which doesn't last, and depression, which particularly if it's long-standing, is sort of a cloud that won't go away, isn't necessarily linked to any event anymore. It just is a state of being. In this case, grief is transitory, something that can be worked through, talk about it, get support, get back to your physical care plan, emotional care plan. Depression may need other professional intervention. And I always say, if someone's experienced depression for more than a year, I think it's good practice that person needs to be evaluated for antidepressant medications. The reality is, anybody who's been depressed for a while, they're just not manufacturing enough serotonin anymore. And whether it's a short or long-term course, I think it's below standard of care if you've got somebody who's been depressed for a while, that you don't at least have an evaluation by someone who's trained to manage the psychopharmacology and say, should we consider a trial of antidepressant? So what do people do to cope with anxiety? We take a deep breath. If you don't do anything else, then take 3 deep breaths. There's a physiological response as you're trying to talk to people, again, how to cope with these challenging times, to, again, avoid relapse, avoid problematic substance use, cope with substance use, keep it from getting worse, having distractions from the anxiety, thinking about the cognitive aspects of anxiety, sort of what are you saying to yourself? In 12-step programs, they talk about the hamster wheel in your head, monitoring the hamster in your head, talking about your fears, good lifestyle change, and then finding whatever spiritual practice. There are a number of ways, but often I'll ask people, how are you coping with COVID? For most people, some combination of getting outside, staying active, being creative, and some kind of spiritual practice seem to be the tools that are helping people cope in these challenging times.
Jim,
yes, sir.
I just wanted to echo the spiritual piece of it. I've seen that recently as some of the churches in the community have. Some of them are starting to gather and they're using, best practices. Others are saying, it's just too soon, but they're trying things like the drive up Bible studies or the drive up. Yeah. And so when people actually have to get in their car and go, even though they don't get out of the car, they're listening to the speaker who's in the parking lot using a microphone to talk through the radio. But it's the actual act of, having to get ready, get dressed, get up, go, and then and then you see people and you can wave to them or whatnot. But we're finding a lot of success there, and definitely the Zoom and the Facebook Live and the other things that are on our computers, internet, have helped. But I think actually having to physically, especially those that are still concerned about gathering, have health issues and are worried about that. They're finding these alternatives.
And very interesting creative ways. Bill, I've heard of Zoom Bible study and people checking on their prayer partners by the phone. And absolutely. The creative ways in which people are staying connected to their spiritual community. And good news, almost every church is streaming something on Sunday morning. So there's a way to maintain some connection. So I started talking about isolation and just kind of recognizing that how we keep people who are socially distant from developing feelings of negative feelings associated with physical distance. We talked about Zoom and FaceTime and whatever else. I found early on that I was doing phone calls with people and email, but that I really needed to see faces. And so for me, getting better with some of the technology we've been talking about, again, creative ways that families and communities are coming together, keeping physical distance, but recognizing it doesn't mean we can't see people. I'm smiling. My neighbors are right across the way. I look right out on their yard, and they bring grandma and grandpa over, and everybody sits on the yard 6 feet apart. And so it's really cool gathering where these grandparents are in their grandkids' lives, where my neighbor is talking to his parents. They're interacting, but they figured out a safe way to do that. Again, the issue of fresh air. When I talk to people, how are you coping? Ask people about their coping approach. People saying, I get out and walk. I get out of the house, and whatever it is. I've heard that so much. And the last reminder here, if you've got people that are elderly you know are in recovery, you know have propensity to behavioral health or substance use problems, to make sure you check in more regularly. Again, that guidance. The last thing I want to talk about today was what we know about people who survive trauma. And the literature on trauma is really clear. Here are factors that create a proclivity to trauma happening. And again, what I'm thinking about here is what we know is a traumatic event occurs, and statistically about a third of people will go on to develop lasting psychological symptoms that are consistent with post-traumatic stress disorder or PTSD. It means 2/3 of people experience that same event: natural disaster, abuse, neglect, alcoholism in the family, and 2/3 of people don't go on to develop symptoms. And so the literature in the PTSD field now kind of talks about what are these resiliency factors. And as part of my conversation about COVID is, if, as I'm wondering out loud, we're in the middle of a kind of natural disaster, free-floating traumatic event, might we as healthcare workers, as social workers, as nurses, might we be looking for these factors that promote resilience and fostering these in the patients that we work with? So social support, obviously we talked about. Action-oriented coping just means, where can I take charge and do something? Again, you think about someone who's going to be more negatively impacted by a traumatic event. I feel hopeless and powerless. Again, action-oriented sort of is the opposite. I'm taking charge, I'm taking control. These are people that are actively taking Zumba classes. They've organized their closets. They are trying new things, that they are doing things on, I guess I'm thinking particular people who are still on quarantine. They are doing things with the time they've got. Self-efficacy means my internal voice says I can do that thing. And so again, if that internal sense is a factor that promotes absence of injury, then we say, how do we build something? Well, you praise, you find support, you find things people can do, you reinforce strengths. All those things are clinical interventions that support self-efficacy. Purpose in life and a spiritual life we've talked about. Talk about feelings, we've talked about that. This last reminder is that people who survive natural disaster, people who cope with trauma, are people that seek help. As we talk about how your individuals at risk for substance use disorder and recovery, people who have active substance use problems, are going to cope with this natural disaster. The idea that some folk are going to need professional help. Again, the argument in favor of brief intervention referral to treatment, that for some people, the difference between developing symptoms of PTSD after a traumatic event, after a natural disaster, and coping is the fact that I sought help afterwards. So how do we keep people safe in the age of COVID-19? I talk about relapse prevention here. Again, I think to just proactively say, I know you've been sober 6 months, a year, 5 years. I just want to know, this is a difficult emotional time. I think that message, this is a difficult emotional time for all of us. And then, have you had any thoughts of using? Have there been any thoughts that could be precursors to a relapse into substance use? And then, what have you done in your recovery? What helps? Who is your sponsor? Can you find your sponsor? Where do you go to meetings? Again, these resources for online meetings that you can share. Second set of questions about, again, anytime you've got somebody using opiates, how are we going to keep you from overdosing? I know you said you're smart. Now, just humor me here. Take some Narcan home. Let's you and me talk about, again, whether it's nasal or sublingual, or intramuscular, how are we going to give someone access to overdose reversal, and talk about how they use it. Again, there are a number of opiate users that are very familiar with overdose reversal, can tell you, but if you're going to distribute, I think just making sure that person knows. And reminders as part of your patient education, risks of injecting, and risks of combining drugs and alcohol and potential problematic use. Bill, let me catch my breath before my thanks. Any questions or any other comment we've gotten on the web? Or
actually, we did. They've kind of come in all at once, but some of these are from our Facebook viewing, and so we had someone, Chastity, stated Ross, ROSS, is a referral for peer support that's out there available.
Super.
So she wanted to share that with us. She said one of the things that we learned first in substance abuse treatments that you can't force treatment on individuals, but you can provide them the tools. And so, we've talked about that a good bit, about providing the tools and whether that's providing clean needles or whether that's providing access to care, whether it's through Zoom or some other available resource. A lot of different things there that we've talked about today. And then the last thing she stated was, I agree, March and April were mostly sessions focused on COVID-19, but then this month's sessions have really focused on personal aspects and kind of going back to what they're dealing with specifically. I think even in our counseling, our focus originally was on what was happening, but we're even tired there, and so we're moving back into the norm. What's affecting me, what's going on in my life, and trying to get back to some normalcy.
Maybe we're integrating COVID-19 into our lives. It's becoming part of our lives.
Sure.
That's helpful, Bill. Let me just reinforce. Most places that are doing recovery have peer coaches, recovery coaches. There's different language, but people in recovery who have specialized training, excellent resource. And sometimes I'm going to be reached by somebody who's a peer who's walked in my shoes in a way that the Mr. or Miss Highfalutin substance use counselor, licensed clinical social worker is not going to reach me. So again, comprehensive approach often involves use of peers and recovery coaches.
The last thing I'd like to just add is that, we've had a weekly call. I've been on a call each week with different groups around the state that are in the social service industry, I guess, whatever you want to call it. And mental health has been there each week. They've also, Alabama's mental health, letting us know that they're still operating, that the service is still available. And so, if there's folks that are watching this that are looking, please know that they're still there and still available, and so reach out to those numbers and those resources that are out there.
Super. And maybe on Zoom or Doxy or something, but they're there. That's great. So we're straight up at the end. I want to acknowledge that this program has been sponsored by the Alabama Wise Woman program. Alabama Wise Woman is a program that's an extension of the breast and cervical prevention programs. Women of a certain age who are at risk for cardiovascular disease, other health problems, are given lifestyle coaching. It's an incredible program that's helped change behaviors and help save lives of Alabama women. If you don't know about that, reach out to Rhonda Holland. I've stolen liberally from the SAMSA, CDC, and NIDA website, so shout out. The Harm Reduction Coalition website is there as well. I want to thank people I've worked with who are living with addiction, that as I thought through pulling this together, I've learned a lot from people who've shared their journey with me, and I want to acknowledge that. Thanks to all the ADPH staff. Rhonda Holland, as I said, is heads the Alabama Wise Woman program, has been generous in giving us guidance and resources to support this. Bill, as always, you're the best MC in the world. The dudes in the control room there who work with me trying to get my slides together, thanks to the guys in back. Most importantly, to those of you who made time to be part of this conversation. Your commitment to your patients, to helping people live through these stressful times is exemplary. I'm honored that people would take 90 minutes and be part of this conversation. I wish everybody the best. Again, as it says there, thanks for making time today, but thanks for all you do to make people's lives better, to save lives, and to improve the quality of people's lives. So again, thanks to everybody at ADPH. Bill, I'll let you wrap up and talk about next steps.
Jim, thank you so much. Thank you for being here. Want to thank everybody for watching today. Do want to remind you that we have 2 more programs related to the COVID-19. The next one is in a couple of weeks related to individuals that are experiencing HIV. And then the last one is for those that are caregivers. And so we look forward to those programs. Jim will be with us on those. Please remember that you can refer back to the training and resources anytime on our demand page on our website. And with that said, have a great day.